yesterday. Our first one is a 54-year-old woman presents to the emergency department with persistent substernal chest pain, nausea, and diaphoresis. Her EKG revealed a 2 mm ST segment depressions in the anterior chest sleeve, and the troponin level is abnormally elevated. Which of the following medications should not be administered in this patient? Here in A. B, I'm hearing. Okay. The answer is Bravo. Okay. So what condition is this describing as far as acute coronary syndrome? NSTEMI. Perfect. So we've got ST depressions, not an ST elevation, so it can't be a STEMI. And then the troponins are positive. And that troponins being positive differentiates this from unstable angina, where you can get those ST depressions, those T-wave inversions, but you have a normal troponin level, and it remains normal. Okay. So when it comes to the treatment of an NSTEMI, fibrinolytic therapies are not indicated, not recommended. Remember, the fibrinolytic therapy was only for patients who had a STEMI who we could not get to a PCI capable facility or get them to the cath lab within 90 minutes. Okay. So that's the only time that we use fibrinolytic therapies. We can do nitro. Anterior leads is a left-sided thing, right? It's not right-sided, so you can still use nitro. Clopidogrel, so from an antiplatelet standpoint, you definitely would. And then an anticoagulant, because you're trying to prevent a progression and development of further clotting so that this doesn't progress from an NSTEMI to a STEMI. Okay? That's really the main goal in the treatment of this patient. All right, our last one is a 68-year-old male presents with 12 hours of continuous substernal chest pain. Heart rate's 110, blood pressure is 80/50. Physical exam reveals a regular rhythm with no murmurs, clear lungs, and elevated jugular venous pressures. EKG identifies a 3 mm ST segment elevation in the inferior leads. What is the most likely explanation for the patient's low blood pressure? Here in B, Bravo. Would you agree with that? Okay. I agree with that as well. Okay. So inferior leads, you're thinking right coronary artery. Right coronary does the inferior wall, it does the right ventricle, and can do a portion of the posterior wall as well, right? But it doesn't really hit the left ventricle. You're thinking more of the LAD, or the left circumflex in that regard, right? Papillary muscle rupture, the reason that that's not there is because we said no murmurs. If there was a tricuspid regurgitation murmur, then absolutely that would be the cause of this. But we said no murmur, so it can't be a papillary muscle rupture. And then a ventricular septal rupture, again, we didn't hear a murmur, and it doesn't look like we're having any left-sided symptoms either, because we're not having pulmonary congestion like you would expect with left-sided failure. So this is a right ventricular infarction. Good. Okay. So I wanted to open up this class with a clinical correlation from when I was a surgical intern at Portsmouth Naval in Portsmouth, Virginia. And we were called down to see this 51-year-old male who had a history of poorly controlled hypertension, hyperlipidemia, 2-pack-a-day smoker, chronic alcoholic, that presented to the emergency room with severe abdominal pain for the past 3 days. The patient was seen in an outside ER 3 days ago for abdominal pain and was discharged with a diagnosis of quote-unquote unspecified abdominal pain. No imaging was completed at the time of that evaluation. He came to Portsmouth Naval, and in the ER he was complaining of diffuse, severe 10 out of 10 pain that did not localize. He was afebrile, his blood pressure was 150s/90s, his heart rate was 110s, respiratory rate of 16, satting 98% of room air. On abdominal exam, he had no rebound or guarding, but he was diffusely tendered to direct palpation. there was a negative Robsing's, negative Murphy sign, and he had quote-unquote pain out of proportion to exam. So let's talk about peripheral vascular diseases, and then we'll come back and revisit this case. So when you talk about peripheral vascular diseases, you have the diseases of the aorta, you have the diseases of the peripheral arteries, then you have the diseases that affect the venous system, and then the diseases that affect the lymphatic system. Okay, and we're going to talk about all four kind of these categories over the course of the next 2 lectures. So today we're going to talk about aortic diseases and peripheral artery diseases, and then our next meeting we're going to talk about the venous diseases and the lymphatic diseases. Okay. So let's start with the aorta. Now, when you look at the aorta, remember there is multiple segments to this aorta. You can't just think aorta and think of just one thing. There's multiple segments, and when you go from the proximal segments to the distal segments, you can see it's kind of a tapered appearance to it. It gets smaller as it goes down and like into the abdomen. But the other thing that's important to note about the aorta is look at all of the important arteries or structures that come off of the different segments. Okay? And that's important to know because as you start to have these diseases develop, you can have the disease of the aorta, but think about, or what you have to consider is what is the consequence of that lesion in that location. If it's in the aortic root, am I taking out the carotids? What's going to happen if that happens? If it's in the ascending aorta or in the arch of the aorta, now I'm starting to knock out the brachiocephalic or the left carotid or the left subclavian. What are the consequences of perfusion problems in that artery going to be? So you've got to think about the disease, but then you have to think about the consequences of this disease as well to all these important arteries that come off of the artery itself. Here's the abdominal aorta. Again, it's tapering down. But even in the abdomen, look at all the important arteries that branch directly off of the aorta. So you're looking at your mesenterics. You're looking at your renal arteries. Imagine what would happen if you knock out the renal artery on either side, right? So there are some major consequences that can develop from the diseases of the aorta that we're going to talk about simply by the location of it. And remember, when we talked about the anatomy of the coronary artery, we talked about how there's 3 layers. There's the intima, which is the innermost layer. Then you have the media, which is the middle layer, but this is also where all your muscles are. This is where your strength is provided to the artery. And then the outer layer is the adventitia, which kind of has all the supporting things that penetrate it to get the blood, nervous supply, nervous system supply, all that kind of stuff to the media so that the artery reacts to feedback and gets the nutrients that it needs in order to continue to function. But let's talk about what happens when you develop an aneurysm or a ballooning of a portion of the aorta. And when you talk about aortic aneurysms, we divide it into 2 main categories, the thoracic and the abdominal aortic aneurysms. And it's important to keep these different because the causes are different based on the location, but then the treatment may also be different depending on the location as well, okay? So what exactly, let's define what an actual aneurysm is, okay? If you have a true aneurysm, you get this ballooning or this dilation of all 3 layers, okay? So all 3 layers are weakened, but they're intact. So you still have some strength to those layers in that aneurysm, that true aneurysm, when you have all 3 layers ballooning and dilating out, okay? Now compare that to a pseudoaneurysm where now there's actually a tearing going on through the intima into the media, so that the only thing that truly is intact is the adventitia, okay? And now you get that ballooning simply because the adventitia has very little tensile strength. And when you have pressures of the aorta, imagine what kind of pressure, what shear forces, stress forces are being enacted on that adventitia. Pseudoaneurysms, as you can imagine, are much weaker than true aneurysms, and these patients are ticking time bombs waiting for this thing to rupture. Okay? Those folks need to get treated immediately before that ruptures and they start bleeding out. So what can go wrong? Why do aneurysms develop in the first place, right? Well, there's a couple of reasons it could be. It could be genetic. You have an inherited disorder, like a connective tissue disorder, like Ehlers-Danlos, Marfan's, or whatever, that causes a degeneration of the medial layer, so the muscle layer, the strength layer of the artery, gets that degeneration from that connective tissue disease, and now that leads to a weakened wall. So that's one common cause of aortic aneurysms. The next one is atherosclerosis. We just talked about coronary arterial disease and the effects of atherosclerosis on that. Think of those principles affecting the coronary arteries. Now let's add that to the aorta. Okay, same things happen. You get that atherosclerotic plaque formation, you get endothelial dysfunction, they can rupture, they're prone to rupture, and that can lead to further problems and weakening of the walls of the aorta. And then you can have the vasculitides, so the inflammatory disorders of the aorta can then weaken the strength of the walls of the aorta and lead to this dilation to occur. But when we go back to looking at aortic aneurysms, we have to have a conversation about abdominal aortic aneurysms, or AAAs, because they are the most common aortic aneurysms you're going to encounter in your patients, okay? So the most common are the abdominal, thoracic is the remaining of it, but it's important that we differentiate abdominal and thoracic because the most common cause of abdominal aortic aneurysms is the things that make somebody at risk for atherosclerosis, okay? So kind of think about risk factors for atherosclerosis. We said diabetics, we talked about smokers, we talked about males, we talked about elderly, we talked about people with lipid disorders. All of those risk factors put this patient at developing atherosclerosis, which then puts them at risk of developing a AAA, okay? And AAAs are much more common, and they're 5 times more common in men than they are in women, okay? So that's why being male puts you at an increased risk of having this. When the patient has this condition, the vast majority of them will have no idea that this condition is there. It may be just incidentally we find it on other imaging scans. If they do have symptoms, it's usually a very vague kind of, my belly just kind of hurts a little bit, I don't know why, I'm a little nauseated, whatever. But it's very vague and very non-specific, okay? Now, if you have somebody who is thin, when you do your abdominal exam, you may actually see a pulsatile mass, depending on how big it is and how thin they are. If it is an obese patient, that adipose tissue is going to hide the appearance of that pulsatile mass. So you can't just go off of pulsatile mass being your defining physical exam finding, because the vast majority of patients, you're not necessarily going to see that pulsatile mass. Okay? But because oftentimes these patients are asymptomatic and there is a risk of rupture, it could be that the initial presenting sign is them coding from hemorrhagic shock because this aneurysm ruptured, and now they're bleeding out into the abdominal cavity, which the abdominal cavity can hold a large volume before it kind of tamponades off, right? So you could lose a lot of blood into the abdominal cavity, causing hemorrhagic shock. So we talked about the pulsatile mass in our physical exam, but the test of choice, the imaging test of choice, is going to be your abdominal ultrasound. And the reason for this is it's the most accurate at detecting the size of the aneurysm. And when we talk about management, we'll see why that's important to know how big this aneurysm is. But the ultrasound is the most sensitive and the best study of choice. You can do it also in the ER with your FAST exam. So if you have an unstable patient coming in and you suspect a AAA rupture, you can do a bedside ultrasound to give the diagnosis for this, and then quickly bring that patient up to the operating room to get this addressed. But you can do a CT in a hemodynamically stable patient, right? This is not the case where you're going to put this unstable patient with a AAA rupture in the CT scanner to get the scan done. You can only, or the CT is really for stable patients, okay? But CT scans can be pretty accurate as well, not as accurate as the ultrasound, but they can be pretty accurate in diagnosing and measurements and those types of things. But because this is such a common condition that we have to be on the lookout for, the U.S. Preventative Services Task Force actually has a recommendation on who to screen for this condition, okay? So what they say is you get a one-time screening in the ultrasound in males aged 65 to 75 with any smoking history. So if they've touched one cigarette in their entire life, they get a scan from 65 to 75. Okay? Even if they are asymptomatic, they're getting a one-time imaging. If it's a male who has never smoked, it's kind of like, risk-benefit ratio, okay, is it really worth it? You could talk to your patient, see what they want to do. Maybe they've got a family history of it, whatever. Okay, go ahead and give them the scan. There's no recommendation for, but there's also not a recommendation against, okay? Now, a woman who has smoked, there's also not a recommendation for or against, so you can get these or do this scan, one-time scan in that population. However, there is a recommendation against scanning for a AAA in women who have never smoked, okay? Just because there's really no usefulness to it is kind of what they have deemed, because unlikely in women, and it's unlikely in women who have never smoked, okay? So the USPSTF, the absolute thing, and you can use this in your ClinCore groups, is males 65 to 75 who have smoked at any point in their life get a one-time screening for AAA. Okay. This is just an algorithm that just shows you what you're going to do. If they're symptomatic, yes, you have to confirm the diagnosis if you don't already know that it is AAA or that they have a AAA. But ultimately, these patients are getting surgery to fix their AAA. Okay. If it's asymptomatic and you do imaging because you did your routine screening according to the USPSTF and you diagnose a AAA, then the guidelines are different in how you treat those patients. They may not need surgery at that time, okay? So it says on the very bottom on the left, manage according to rupture risk, okay? And we'll talk about rupture risk after we talk about thoracic aortic aneurysms so that we can see when would we do surgery for a patient and when would we not, and just continue to monitor. But ultimately, somebody with a AAA, if they don't meet the criteria for surgery, the way you treat it is you manage those risk factors to prevent the progression, the enlargement of that aneurysm. So let's do things to stop the weakening of the arterial wall so that that aneurysm doesn't continue to get larger. So what do we got to do? Okay, smoking is a risk. We can fix that, right? I can't change the male gender, so I can't do that. I can't make them younger, so I can't do that. So you're kind of stuck with, let's manage tobacco, let's manage their hypertension, and let's manage their lipid profiles. They don't continue to develop these atherosclerotic plaques that lead to further harm, further damage. Now let's go to the thoracic aortic aneurysm. Okay, so this is the part of the aorta above the diaphragm. And remember, when we said triple A's, think of atherosclerosis as the main cause for this. With thoracic aortic aneurysms, be thinking connective tissue diseases. Okay, so be thinking of your Marfan's, be thinking of your Ehlers-Danlos patients, because that's who gets thoracic aortic aneurysms. And when a patient does experience this, it's typically going to be in the ascending aorta portion, or most commonly it's going to be in the ascending aorta portion of the aorta. Okay, kind of think of it, what kind of pressures is that region of the aorta experiencing? Because it's under the direct influence of that left ventricular squeeze. Okay. So how are these patients with thoracic aortic aneurysms going to present? Well, they could be completely asymptomatic, have no idea. You did a simple plain film chest x-ray, saw a widened mediastinum, and that's how you diagnosed it. Okay. So completely asymptomatic. But what if that aneurysm is in a location where it starts to affect the function of the phrenic nerve? You get like that cough, right? What happens if it hits the recurrent laryngeal nerve? It could start to cause hoarseness, right? It starts to affect the function of the vocal cords and stuff like that. So that may end up being kind of the presenting signs of a thoracic aortic aneurysm is other structures' function starts to be impacted because of that enlarged area. Okay. On physical, what can you see? Well, if that is affecting the ascending aorta, then I might be affecting the blood pressure or the blood flow, the perfusion of the right subclavian. So I may have a diminished pressure on the right, whereas the left may be normal or vice versa. Okay, so you can see this left versus right blood pressure difference. You should be relatively symmetrical between the two. So if you're seeing a difference, then that is concerning. Okay. The other thing you may appreciate on your exam is an aortic regurgitation if this aneurysm is affecting that aortic root. So it's affecting the aortic valve. It causes the valve leaflets to get pulled apart from each other, which then leads to that regurgitation of that valve. Okay. So that's what you might find on your physical exam. With your imaging, okay, chest x-ray, you may see that widened mediastinum, especially at like the aortic knob. So you may see that on your plain films. But your echocardiogram is going to be your test of choice because it is the most sensitive and it's the most specific test in order to diagnose this thoracic aortic aneurysm. Okay. Now, how do you treat a thoracic aortic aneurysm? Well, we got to control the blood pressure. Imagine if you have an elevated blood pressure and you're having that higher blood pressure hitting that weakened aortic root or the ascending aorta, imagine the risk of it rupturing. Okay, so you've got to manage blood pressures aggressively in a patient with a thoracic aortic aneurysm. And now other things like beta blockers are kind of decreasing our cardiac output, so that can also take some of that stress. It slows the heart rate down, so I have more diastolic time, which means that diseased affected aortic area now is being exposed to diastolic pressures longer than systolic pressures, okay? So you're kind of taking some of that strain and stress off of that diseased portion of the aorta. Now, normally when we talk about ACEs and ARBs, we talk about ACEs are our preferred and ARBs are for those who just can't tolerate the ACE, right? But in this case, actually the ARB is recommended over ACEs as your first line. And the reason for this is ARBs interfere with the transforming growth factor beta. Okay, so basically it affects this compound that will then further weaken that aneurysm. So it kind of slows the progression of the aortic aneurysm. So ARBs are preferred over ACEs in this case. Going back now, this is for AAAs and for thoracic aortic aneurysms, okay? If I am asymptomatic and I do my ultrasound and I confirm the presence of an aneurysm, how do I know who would benefit from surgery and who would not? And the answer goes down to, well, what's the size of the aneurysm? Do they have any connective tissue diseases? And how fast did that aneurysm grow in the past 12 months, okay? So knowing that, you can see for somebody, a normal individual, you don't do surgery until that aneurysm is greater than 5.5 centimeters in diameter, okay? So 5.5. But if they have connective tissue disease, and they have like Marfan's, then once it gets above 5 centimeters, you're doing surgery. If they have Loeys-Dietz, then it's 4.5 centimeters, because in that condition, that weakness that develops in the aneurysm is a lot more, there's a lot weaker than even in Marfan's, so that threshold for surgery is much less, okay? The final criteria for surgery is the rate of the enlargement. So in the past year, what was that rate of growth? If it was more than 1 centimeter, then they're going into the operating room to get this fixed, because how fast this thing is progressing. So it could be that it's only 5 centimeters, but it was 4 centimeters last year. Because of that rapid growth, the assumption is that it's going to continue to rapidly grow to the point where they could rupture even before our next ultrasound is completed. So rate of enlargement of greater than 1 centimeter in 1 year, or 5.5 normal, 5 if they're Marfan's, and then 4.5 if they're Loeys-Dietz. Okay. So how do we fix this? Well, you're going to do a surgical type of procedure, but you have an invasive decision or a non-invasive or minimally invasive decision to make in this. The invasive one is you open up the abdomen, you isolate the abdominal aorta or wherever the aneurysm is, and then you cut out, you removed the diseased portion, and then you attach a graft like I passed around today in its place. So you just remove that disease and then you just put in a synthetic graft in its place, okay? But you've removed the diseased portion. Now the minimally invasive approach is I thread catheters up through the aorta to the area that's diseased, and then I will deploy a graft, an endovascular graft, kind of think of it as like a stent in the coronary artery, where I am bridging that diseased area. So now you have healthy aorta, the endovascular graft, healthy aorta on the other side, or in this case, the iliac arteries after the branch. But the diseased portion is still there. It's just the graft is inside that lumen, and it is taking that stress and that strain off of that diseased portion of the vessel. Okay. We would prefer endovascular because it's better tolerated, faster recovery, lower intra-op mortality, but it could be dependent on a number of factors which one they choose to do. Okay. Questions on aortic aneurysms before we move on to aortic dissections? All right. So aneurysms was a weakness of the wall, the layers of the wall of the artery. But let's say what happens if something traumatic or something happens that causes a tearing of the intimal layer. What are the secondary consequences of that going to be? And that's where the dissection comes in, okay? So a dissection is there's a tearing of that intimal layer to the point where now you start to get a separation of that medial layer and that intimal layer, which now allows blood to get in there. But that blood's going to be stagnant, right? Which then means it's going to clot, which the media has the strength of the artery, right? So it's probably not going to dilate out too much, if any. So where is that going to go, or what's the impact going to be? It's going to go in. And if that bleeding gets worse and worse, that lumen gets narrower and narrower, you could get to the point where you have no blood flow going through that portion of the aorta. Imagine the consequences of that and what that would be. Okay. In this image here, basically we cut the diseased portion of an aortic dissection lengthwise and then fillet it open. And you can see here's your clot on both sides. Here's your intimal layer. And this is the medial layer right in here and the adventitia. But you can imagine how that is impeding on the lumen of the aorta and what that could lead to. Fortunately, this is not as common as like an aortic dissection, but it still occurs in about 2.6 to 3.5 in every 100,000 patients. It typically is a male patient who is elderly who gets this. And the reason that this can develop is either I am a poorly controlled hypertensive, or I have a condition that leads to a hypertensive crisis that leads to that tearing. So that's one instance of it. Okay. It could be, the vasa vasorum, those are the vessels that support the wall of the aorta. Let's say that one of those arteries rupture, and now you're bleeding into that area. Blunt chest trauma, so think of steering wheel to the chest in a motor vehicle accident without airbag deployment. Or we did it when we're trying to do a catheterization procedure. So we're trying to treat this patient's heart attack, and we're threading catheters up through the aorta, through that artery, and we are just a little aggressive, and we push the catheter through the intimal layer, create that hole that leads to that dissection and that development. So iatrogenically, we did something that caused the damage to the vessel wall, leading to the development of this condition. So if it's not one of those things, what else could it be? Well, it could be atherosclerosis. Again, endothelial dysfunction develops, and we're causing shear forces, stress on the wall, especially the intimal layer of the wall, leading to that space to get created so that that blood can travel into that space and cause the problem. It could also be a connective tissue disorder, that also leads to that. So you can kind of see some commonalities of this versus aortic aneurysms. But when we go to diagnose a patient with a aortic dissection, we used to have a pretty complicated classification system called the DeBakey system. Fortunately, we don't use that system very much now, but it may be still in some of the literature if you read on this topic, so you just have to be familiar that there is another classification that means something. But we use the Stanford classification now, and it's much simpler, okay? So type A, which is the most common type, is a proximal disease. And so if any portion proximal to the left subclavian is diseased, then it is a type A, Stanford classification aortic dissection, okay? So if any involvement proximal to that left subclavian, you've got a type A. If it does not involve anything proximal to the left subclavian and it's all distal to the left subclavian, then that is a type B. And that's about a third of your patients who encounter this. And that's important to properly classify these patients when we come and start talking about treatments, which we're going to talk about in a couple of slides. But this classification is really important because it tells us what to do next. Okay? So your patients who have an aortic dissection, they may come to you complaining of like this tearing, ripping chest pain or even a back pain sensation, depending on which portion of the aorta is affected by this tearing. But they'll commonly have that tearing sensation. They could be presenting with a complication related to one of the branches off of the aorta that's being affected by that dissection. So if it affects the arch, maybe they're going to be presenting with a stroke because the carotid artery is affected by it. Okay? So that could be the presenting sign in your patients. On your physical, you're going to see, or you could see, this asymmetric blood pressure from right side and left side. Because of that tearing and that occlusion, it could impact the blood flow to the left compared to the right. They could be presenting with neurologic complications related to poor blood flow and affecting the central nervous system. So the presentation could be pretty broad depending on what's going on. Now we said, don't ever let your patient die, an unstable patient die in the CT scanner, right? Especially when we talk about an aortic aneurysm. But you'll see on this, if you have a hemodynamically unstable patient, before you bring him to the OR, you're getting a CT. You may be wondering, well, why are we putting an unstable patient in the CT scanner? They're going to die, right? Well, the answer to this is, if I have, or I know that somebody has a thoracic aneurysm, I open their chest, I will see the aneurysm, where it's located, what area is diseased, so I know how to fix it right away, right? But with an aortic dissection, if it doesn't balloon out, how do you know what area is diseased without doing an internal investigation, right? So how do I know internally where is this dissection so I know exactly where I got to go to fix the problem? If I think maybe it's here and I remove that portion of the aorta and oops, wrong place, let me move up. And I keep moving up trying to find it, I'm guessing, you can see how that's one, going to delay treatment, but two, it's probably going to kill him, right? So putting him in a CT scanner, I can see and diagnose exactly where that dissection is. So as soon as they're done with that CT scan, I'm in the operating room and I'm fixing the problem. So I know exactly where to go to target it, okay? So the benefit of doing that CT in that unstable patient is better than that risk there, okay? If you have a stable patient, then most institutions prefer to do a transesophageal echo in order to diagnose the location of this tearing, okay? So TEE is recommended in most institutions for a stable patient, but in an unstable patient, you're bringing them to get a chest CT done, okay, or a CT, depending on where the location of the tearing is. So. But let's say you have a patient who you're working them up for chest pain. You may be thinking it's cardiac, and then you do a chest X-ray. What could you find? Well, it kind of depends where the location of it is, but you may see that wide and mediastinum, especially with that aortic area. You may start to see some effects of bleeding and stuff. And your EKG may be normal, but if it's affecting the aortic root and the ostia to the coronary arteries, you may actually have evidence of a STEMI present there. So how are you going to treat these patients? Well, these are going to be patients that you're not going to discharge home. You're going to have to admit them to the hospital, probably to the ICU. You are going to treat their pain. They're going to be in a lot of that pain. Remember, one of the common presenting symptom is that tearing, ripping sensation, right? But remember, when we talked about hypertensive emergency treatments, one of the special conditions that affected our management was aortic dissection, right? And we talked about how we had to be extra aggressive in lowering that pressure. Same goes with, in this case, where maybe they're not in that hypertensive crisis or emergency kind of range in their blood pressure, but we still want to get their blood pressure down below that 120 so that we can take a lot of that stress, that strain, that shear force off of that tear so it doesn't continue to get worse, okay? So aggressive blood pressure management will be important, okay? And then we talked about how it's important to determine type A's versus type B's. In a type A patient, these patients are going to require surgery all the time, okay? So type A, we said, is any involvement proximal to the left subclavian. If it's type B, so anything, all of it is distal to the left subclavian, then we may be able to manage this actually medically without having to do a surgery, okay? Well, that's kind of interesting, right? Now, there are some caveats. So if it's starting to affect other branches of arteries, then yes, you're going to have to treat it surgically. But if it's not affecting anything, then medical management is the preferred ways to do that. That brings us to 8:50. Let's take 10 minutes, come back, and we'll talk about why we can treat type Bs medically versus surgically.
Thanks, sir. I got the cheap ran about my yeah, after one day. Oh, boy. It's like freedom of space.
Do you ever sleep when you're it's like it's thinking of stuff that I'll be like when you kind of like wake up a little bit, you're like,
If you do, so if you do this, so if you go into like, so I did like four of them, right? So I did high yield questions, I did that. So say I want to do another one, you click new, you do import cards, and then you do this CSV document. So when you do it in Gemini, if you click, like if you say, please make this document into a .csv, I can't do it on here because you got to do it online. So you can't do it in the app, you have to do it online. So I do it, I have a mini Mac that links has this link to it. So what I'll do is I'll go on there, and then what it says is like, it'll say name of deck, and then you just copy that CSV, and it'll say you can either separate by colon or and whenever you do it in Gemini, it's separated by colon. So it'll look like when it's like making the thing, when you first do it, it'll look like all your cards. Just change it from the semicolon to the semicolon, and it'll make it. And you can do it like I think I did 100 sentences. So like this one. So I did 8. This one didn't upload right, but so like this 10 I did 15. I usually do about 50. But yeah, so 30 for that one.
No, I'm asking you, like, you know how right now mine's kind of set up like this, but it'll only let me study 10 minutes. Is there a way to increase how many? And like I know it takes like 10 minutes to refresh.
So if you do,
Hey, you got your tea ready?
yeah,
so it's like
if you do study cards,
so I'll go through a thing
and then you go through all of them,
Put it in there and say, yo,
continue, and go back here.
So mine was at 10 minutes. So I was just like, that kind of I know there has to be a way to change this, and I'm like, I really use it a lot. But I might just have to wait it out.
I usually just do it. I don't go.
Yeah.
I've also done
I did it before and it shut off, and then I just did it again because it probably was cooler. What?
Yeah, well, like, I also saw a study about water too. So basically, over time, it's
I'm curious who subscribed. 99 people. 33 people. Probably sophomores.
Some sophomores.
If they don't have somebody recording.
What's that?
So if they don't have somebody recording. Wild to look at. Yeah. Just trying to figure out how to record it.
So I would tell my brother, like, so I'm gonna need hemorrhoid and like injury, things like that. For how long? I was like, don't listen to the guy when it's pretty dissertation.
So I have to use is one more than use.
You said like, I told him specifically.
That's not the only problem with that weight.
Like I like to my I was just not really paying attention. Was it like 4.9? 5.5 and then this is at like 2 points. I'm like, I learned is his blood pressure is always
Her blood's not bad.
You would think that.
Do you nicotine or anything?
Doesn't really drink. So you don't I should like you would think you'd be in so much pain. It's like, yeah, I'm pain every once in a while. I'm like, dude, 400.
All right, let's get back to the lecture. So we said type A dissections, you're gonna get surgery all the time. Type Bs, we may be able to treat these medically. But when we do a surgery, we have to remove the area where the tear is located and any progression of that tear. Okay, so you may be removing a large section of the aorta to address this condition. And you can kind of look at how complex this repair could be. Okay, here is just a cartoon graphic of it where you have like a proximal tear. I remove the ascending aorta, replace it with grafts, but now I got to reattach all of the aortic arches, the arteries that come off of the aortic arch to this. So now I'm doing this little, graft, complicated kind of repair. But oh, by the way, I also have this area that's diseased. So now I'm going to have to do like an endovascular graft. So I'm threading wires up to kind of bridge that area. And oh, by the way, it affects the branches of some of the other major arteries like the mesenterics or the renals. So now I'm having to put grafts into those arteries to ensure that they're getting the perfusion that they need. So you can imagine how complicated this type of procedure could be depending on the location and the extension of that tear, which that's also one of the reasons why we do that aggressive blood pressure control early, is because we want to prevent that progression, which then could lead to even worse morbidity and mortality. So it's pretty aggressive, or can be a pretty aggressive surgery to replace the diseased and damaged areas. So let's revisit, well, why is it type A's are always treated surgically and type B's can be treated medically? And it kind of comes down to risks, benefits, right? So if I have a type A aortic dissection and I immediately bring them back to the ER or the OR, I'm looking at a 25% mortality that they're going to die in the operating room. If I try to treat that medically, they have a 60% mortality risk. So 60% chance they're going to die if I just try to treat it medically with anticoagulants, antiplatelets, antihypertensives. Okay? So the risk benefit is better to go to the operating room. Granted, they still have a 1 in 4 chance of dying on the OR table. But that's better than 6 out of 10, right? Now compare that to a type B, where you have, again, it's all localized distal to that left subclavian, where, okay, your surgical repair is about the same as it was for type A, it's about 1 in 4. But look at what the risk of death is if we treat it medically, if it's not affecting any of the other branches of the arteries, okay? I have a 9% chance of death in treating a patient with type B aortic dissection medically. So now that ratio is flipped, where now I have a higher risk of this patient dying if I bring him back to the operating room than if I were to treat them medically with anticoagulants, antiplatelets, antihypertensives. Okay. So type B's, that risk-benefit ratio is flipped in favor of medical management. Okay. So that's why we can treat type B's medically. Questions about aortic diseases before we move on to the peripheral arteries? Okay. So there's a number of peripheral arterial diseases that the PANTS blueprint requires us to talk about, and we're going to really focus on the ones that it tells us to. This is not an extensive list. Okay, there's many more conditions out there, but these are the ones that they are likely to test you on with the PANTS. Okay. So the first one we're going to talk about is a peripheral atherosclerotic disease. Okay. Kind of think of this disease as stable angina with maybe a progression to ACS depending on the severity of symptoms and stuff like that, okay? So you're gonna kind of see some similarities when we talk about peripheral atherosclerotic arterial disease with our lectures from the ischemic heart disease and ACS, okay? So who's at risk of this? Well, atherosclerosis is in the name of the disease, right? So probably this is a disease related to atherosclerotic plaques and formations of these plaques within the arteries, right? So what are the risk factors of forming atherosclerotic plaques? Same risk factors, okay? It's just now that location is in one of the peripheral arteries. And when patients have this, a vast majority of them are going to be asymptomatic. Remember, when we talked about stable angina, they didn't have symptoms until you had 70% stenosis, and then you started getting symptoms with exertion, right? So what's happening from that 0 to 70%? They're completely asymptomatic, right? Same goes with peripheral arterial disease, where they go a long time without having any symptoms. But as that stenosis gets worse, let's say it approaches that 70% or starts to hit 71, 72%, then they start to get this intermittent claudication, okay? And this is exactly like stable angina, okay? This is a pattern of predictable onset of symptoms of pain with exertion, okay? I know that if I walk half a mile, I'm okay. As soon as I go over half a mile, I start to get cramping in my legs and such, okay? So similar to stable angina, right? Now let's say that that stenosis progresses or that plaque ruptures in that peripheral artery, and now you get that acute clot formation, and now you're in an acute coronary syndrome-like condition. This is critical limb ischemia, where now you start to have minimal to no blood flow going to that extremity, and now that extremity is going to die because it's not getting the oxygen and nutrients it needs to continue to function, okay? So you can see this spectrum of presentation for this condition. So this is a chronic problem, so there's going to be a chronic progression. This is not a condition where you're fine one day to then not fine the next, okay? So it's going to be a chronic thing. And you can start to see some of these chronic type of changes, okay? And you can see, you know, skin pallor, coolness, hair loss, nail thinning. You may even get like these ulcers that are forming just because you're not getting the best blood flow to the area, okay? But as that perfusion deficit progresses, you may then start to develop dry gangrene, which is a black discoloration without exudates. Kind of think of this as your end stemies. Or you can get a wet gangrene where you have that black appearance, but now you have that exudate that's present. And this is the equivalent of a STEMI. And here's an example of that, okay? So you see that blackened toe, but here's the purulence and stuff. So this is wet gangrene. Here's just the blackened toes without the purulence. So that is dry gangrene, okay? And when you cut into these things smell so bad. So worse smell you're going to have in medicine is cutting into one of these dead extremities. But you got to have a differential diagnosis. You can't just be like anytime somebody is exerting and has leg cramping that this is peripheral arterial disease, because there are other things that can cause this. So for instance, nerve root compression, okay? So they have a herniated disc. In your healthy population, you sneeze funny, you're going to herniate L5-S1, okay? In the military, we do a lot of heavy lifting, right? And that It's going to cause herniations of discs in multiple areas, but very, very common in the medical field that you're going to practice in. But what happens if that disc that's herniating starts to put pressure on the roots of the nerves as they exit the spinal cord or exit the vertebrae? How is that going to affect those symptoms, okay? And so usually that pain that they're going to have is going to follow that dermatomal pattern, right? It's not going to be the whole leg that's like that. It's going to be a specific dermatome that they're going to experience that cramping and pain and such like that. So, but there is a differential diagnosis to somebody experiencing leg pain with exertion. Okay. So their symptoms, if they are having claudication, is going to be similar to stable angina. So as I'm exerting myself and I go over a certain threshold of exertion, I'm going to have pain. I stop that exertion and I rest, the pain will go away, okay? So it's predictable. Other things, depending on where it's affecting, which peripheral artery is being impacted by this, you could have some additional symptoms, so like extremity weakness, erectile dysfunction, pain at rest, although this would be the equivalent of unstable angina. So that would be kind of that impending critical limb loss kind of concern, okay? But to help you diagnose this, you can do a test called ankle brachial index, okay, ABIs. And what you're going to do with this is you're going to take the blood pressure in the upper extremities, see which one's higher, and then you're going to take the blood pressures in the lower extremities. And usually we're looking at like DP or PT pulses. And you may be wondering, well, how do I take my blood pressure and isolate just the DP or the PT artery? So usually what people will do is they have a Doppler that they will put over the artery, inflate the cuff to the point where you're not hearing blood flow anymore, slowly deflate the cuff with your ultrasound probe or your Doppler probe still on that artery until you start to hear that return of blood flow. And that's your pressure, okay? That's your systolic pressure. So once you've taken those, then you're going to take the higher of the two as far as PT or DP, and then you're going to compare that to the highest value of your upper extremity. And you can see we then get a ratio. So in the right, the ABI here is 0.57, and in the left, it's 1.13. That's what it said, right? Yeah, 1.13. So now you got values. What's normal and what's abnormal? Well, fortunately we have a chart that can tell you and give you that diagnosis. So now you have that objective data. Now let's use that objective data to give us that diagnosis. And you can see a patient with a normal ABI, you're going to get a value of anywhere from 1 to 1.30. Okay, that's the normal range. If it's 0.91 to 0.99, that's borderline. Anything below or equal to 0.9 is consistent with peripheral arterial disease. So going back to our example, we said on the right it was 0.57. So now I now have confirmed that the right is diseased. Okay? But look at the left. The left was 1.13, which puts me in that normal range. So the left is not affected by this condition. Okay? Now, if you get a value of greater than 1.30, so you're in that 1.31 or higher, this is also consistent with peripheral arterial disease. But the reason for this is you have so much calcification and chronic changes to that atherosclerotic plaque, you might as well just think of it as like a bone. It's not compressing down. So you can't really get a good read on blood pressure because it doesn't collapse down with the pressure. So that's what you see if that ABI is greater than 1.30 or greater than 1.31. What else could you do in addition to APIs? Well, you could do CT angio to look at the flow problems. You could do a Doppler ultrasound to look at it and see that flow discrepancy, where the narrowing is, and all that kind of stuff. So there are some imaging tests that you can do to help you with the diagnosis of this condition. But if this is a condition that is caused by atherosclerosis, does it make sense the best way to treat this is to treat the risk factors for atherosclerosis? We talked about in the atherosclerotic lipid disorder class, we talked about how treatment kind of focuses on managing lifestyle choices. So let's stop smoking, let's manage let's eat healthier, let's lose weight, let's manage our diabetes. But with this condition, exercise is actually going to be even more important to do because with that exertion, I start to induce some chronic changes to compensate for this perfusion problem. So what ends up happening is if my calf muscles or my right leg are not getting the blood supply that it needs, and I keep exerting myself and putting that strain and that pressure on that area, then what happens is the body recognizes that there's a perfusion problem and I need to reroute plumbing in order to fix that problem. So you actually get new blood vessels, new arteries that form and grow to perfuse that diseased area. But this is something that takes time to develop. It's not something that just happens all of a sudden. So by having them exercise, they are getting that collateral circulation to address that perfusion problem. Okay. But if their claudication symptoms are interfering with their ability to have any kind of meaningful exercise to challenge the body to make that collateral circulation, then you can give them silestazol or Pleal in order to help with that exercise. And you can see the reason that we would give somebody silestazol is to improve their symptoms and increase distances. So we're increasing their exertion level before they start to have those claudication symptoms. Okay, so I can have that patient go a little further before they have to stop because the claudications are just too painful. Okay. Statins. So we're managing the LDLs. We're managing the cholesterol levels to limit the progression of those atherosclerotic plaques, right? But we also are stabilizing those plaques so you're less likely to have a plaque rupture that then leads to the development of that acute limb ischemia. Okay? So that is an additional benefit of statin therapy in these patients. Aspirin, you're going to give it to them. When we look at what are the indications for aspirin use, you can see one of the indications is peripheral arterial disease. If they are aspirin sensitive and can't take aspirin, then clopidogrel is approved, and one of the indications for it is peripheral arterial disease. So you're having some form of antiplatelet to prevent that acute occlusion of the vessel, okay? But some of these patients are going to have to get surgery, and usually we're thinking of patients who either, we're giving them, they're doing the lifestyle changes, they're on the silestazol, and their exercise tolerance is getting worse, then we may need to go and do a surgery, right? Or it rapidly progressed to an acute limb ischemia. Now, maybe they need surgery to fix that, right? Because we don't want the leg to die on them. And the way that you fix this is basically you bridge okay artery flow around the diseased artery flow to the distal portion where that flow opens up. And you can do this with a couple of different grafts. So common ones we usually think of is a fem-pop graft, where you take the femoral artery and you put that graft, like the material that I passed around, you put that around the femoral artery and attach it to the popliteal artery, so that fem-pop graft, it restores that blood flow to the calf muscle and to the foot. Okay. The other type is, or common type, is this aortofemoral bypass graft right here that you see. And what that is I take that graft, attach it to the aorta proximal to that diseased area, and then I attach it distal to the diseased area, like in the femoral artery. So that's aortofemoral bypass. Okay. So those are common peripheral arterial graftings that you can get. Now, going back to ABIs and how we manage these patients, who would benefit from surgery and who would benefit from lifestyle choices or lifestyle changes and exercise. Well, typically, if they are having symptoms and we do their ABIs and it's less than 0.90 or greater than 1.3, then we're sending them to the vascular surgeon. They're doing some additional testing, and they will then make the decision on doing surgery or not. If we get an ABI of 0.91 to 1.3, so we're in that borderline to normal ABI range, then we can do some exercise testing. Kind of think of it as we're doing a stress test on your peripheral arteries. And now we want to see what happens. Is it that the exertion made the ABIs worse? Well, then that's concerning, right? With exertion, my ABI gets worse, and maybe now they would benefit from a surgery. So the ABIs can help you determine treatment disposition for those patients. Okay. So that was a condition where the plaques developed. They started to stenose the artery. But what happens if, let's say, we have an acute occlusion of the artery? So instead of chronic, it's an acute problem where, let's say, a patient has AFib, they form a clot, and instead of it getting thrown up to the brain to cause a stroke, what happens if it goes to one of the other peripheral arteries and occludes that artery? Okay, and that's where we talk about this thromboembolic peripheral arterial disease, okay? And there's lots of things that could set somebody up for this, to include an atherosclerotic plaque rupture, okay? And what can happen, think of this as a stroke, but affecting the peripheral arteries. And depending on which artery, which branch of the peripheral arteries this affects, is going to determine the symptoms, the presentation, the complications related to that acute occlusion, okay? So if it goes and it knocks out, say, like the femoral artery or the popliteal artery, then I'm going to have this acute limb ischemia that, you know, if I don't treat it within 6 hours, could lead to irreversible damage and dead tissue, okay? If it goes to the mesenteric arteries, and now I'm occluding a mesenteric artery, and that blood can't get past that occlusion, now you're talking about dead intestine, okay? So depending on where that clot and that occlusion occurs is going to determine their presentation and kind of their acuity to treat it. But regardless of where you get this acute occlusion, you're going to get the 6 Ps, okay, to be able to diagnose it. So you're talking about pain out of proportion to exam, okay? They say they're in 10 out of 10 pain. They look like they're 10 out of 10 pain. But you do your abdominal exam or you do your exam, and you're like, this doesn't make any sense that you're in this much pain, right? Because we're not able to test for that ischemic pain that's occurring, right? And this is very different than your active duty folks that come in and say they have a 10 out of 10 hangnail pain, right? And they're sitting there on their cell phones just scrolling. Like, these people look sick, they look like they're in pain, but their physical exam just does not make sense why they're in that much pain. Okay. Pallor, if I'm affecting blood flow to an area and there's no blood getting there, you can imagine it's going to become pallorous, right? Paresthesias, I'm affecting those sensation or those sensory nerves. So now they're not getting the blood flow that they need. They stop functioning. So now I'm not detecting that numbness or that tingling. Or I'm not detecting any sensation, so I get numbness and tingling. Paralysis. If I'm not perfusing muscles with blood, with calcium and all the other nutrients it needs to function, then they are going to stop functioning. Okay? Poikilothermia, this is just a fancy way of saying cold. We just needed to make it a 6P instead of 5 Ps and a C. So poikilothermia is a cold extremity. If I'm not getting blood circulating, then I'm going to lose that temperature. It's going to have that cold extremity. And then the last P is pulselessness. So you're not going to feel a pulse going down distal to that obstruction because there is no blood flow to that area. So those are your 6 Ps to help you diagnose that acute thromboembolic disease. Okay. So how are you going to treat these patients who present with this acute occlusion? Well, the first thing is, let me stop the progression of that clot to get bigger. So I'm going to put them on some kind of anticoagulant like heparin. And then I'm going to have to do an additional type of procedure in order to get rid of that clot. Okay? So you're talking about going in and doing a procedure, removing that clot. You're talking about either doing a stent across that clot to restore blood flow, or you're talking about surgery where you're going in and you're removing the affected area to then restore blood flow. Okay. Now you may be wondering, okay, why is it heparin is used instead of enoxaparin or a low molecular weight heparin? Anybody know the answer to that? Protamine sulfate. What does that do? Reverses heparin. So I bring them to the operating room. They're bleeding because I got them on heparin. I can just give them some protamine sulfate. It reverses heparin, and now they can start clotting again, right? Whereas low molecular weight heparin, I don't really have that reversal agent, so they are going to continue to bleed, right? So, so heparin is the anticoagulant of choice for this because I can reverse it if I need to in the operating room. Okay, so that was the acute thromboembolic disease. Let's move on to the vasculitis or inflammatory. Unfortunately, there's a couple of different types of this, but PANCE says giant cell temporal or giant cell arteritis is the only one that they want you to know about, okay? So giant cell arteritis affects medium to large arteries. It's not very common, but the key demographic tends to be females over the age of 50. Okay, so if you have a 20-year-old male, probably not going to be giant cell arteritis. Okay, and the presentation is going to be dependent on which, like, facial the head kind of artery that's being affected by it. So it could affect the temporal artery, which normally we think of headaches, not uncontrolled headaches in the temporal area as being due to temporal giant cell temporal arteritis. It can affect the facial artery, which usually is going to be with chewing. It's a problem. Or it could be the ophthalmic artery, where now its vision is being impacted because of this inflammatory response that's restricting blood flow through that diseased area. So how are you going to diagnose it? Well, this is an inflammatory disorder, so your inflammatory markers are going to be elevated, so your ESR, your CRP, but that's not specific, right? That just tells you that there's an inflammatory response going on somewhere in your body. So the way that the gold standard to diagnose this is to do a biopsy of the artery, and you can then see that inflammatory reaction under the microscope. But you could do an ultrasound of the artery, and you'll see this hypoechoic halo, that's that inflammatory response around the artery. You'll see that on your ultrasounds, or can see that on your ultrasounds. And then once you diagnose it, the treatment is you give them high-dose steroids to stop that inflammation, to reduce that inflammation affecting the artery so that blood flow can then be restored through that artery. So you're going to need high-dose steroids for an extended period of time, which means you're going to have to do a tapering dose as well. Okay? And using your ESR-CRP can help you determine when you can start to step down the dosage and do that tapering regimen. Okay. Our second to last condition is the vasospasm vascular disorders, which the most common one that we think of in this is Raynaud's. Okay? But Raynaud's phenomenon, usually we'll see like this color change to like the extremities, most commonly like the fingers, but it can affect the toes as well, where there's some type of stressor that triggers this spasm to occur in these smaller arteries going into digits. And it could be something like cold temperatures, but it can also be something like an emotional stress that triggers this condition. And you can see the typical change in color that you're going to see and the progression of this color change that occurs with this. But there is primary Raynaud's, which is that vasospasm, usually affecting women 20 to 40 years of age. But secondary Raynaud's is there's some other condition that is triggering this vasospasm. And that could be things like lupus. That could be carpal tunnel, where the nerves are being affected, the regulation of the nerves is being affected by it. But usually, these patients are going to be older than 40. And because they have this other condition that's triggering this, as opposed to just a uncontrolled, unprovoked, or this provoked spasm, they tend to have complications related to it, like ulcerations, because there's nothing that tells it to stop spasming. You know, if the cold triggered that spasm to begin with, I then put gloves on, or I go inside, I warm up my hands, that spasm stops, right? But in these conditions where it's secondary to something else, you don't get that change once you've addressed the trigger for it. So how do you treat it? Well, if it's primary, avoid whatever the trigger was. So if it was cold, then don't go outside when it's cold outside, or especially not with like gloves or mittens or something to keep your hands warm. If you have persistent symptoms, then you can take something like calcium channel blockers, like your amlodipine. We kind of think of this as like your variant angina or your Prinzmetal angina, where you take a calcium channel blocker to block that spasm. Same goes with this condition. So you can use amlodipine, felodipine, whatever, the pine calcium channel blockers in order to prevent this condition to happen. If it is due to lupus or some other secondary cause, then manage that condition, and then this condition will get better. Okay. All right. Finishing up, the last condition that they wanted us to talk about was arterial venous malformations. Okay. So what exactly are they? So the artery, high pressure, right, turns into capillaries, which are low pressure, which allows for the oxygen and nutrient exchange and carbon dioxide exchange to occur, right? Low pressure. And then that leads into the veins. Again, low pressure. But what happens if I bypass capillaries and I'm going artery directly into veins? The veins are not designed to handle that higher pressure. So what ends up happening is they stretch, they get engorged with blood, and they start to see pressures higher than they should normally see. Well, that can then, because of that high pressure going into that low pressure system directly without that capillary bypass, it can start to have symptoms like buzzing in the ears, headaches, depending on where these AVMs are located. Probably one of the most common causes of an arterial venous malformation is something that we intentionally do in medicine in our patients who require hemodialysis, right? Imagine hemodialysis, they're hooked up to a machine for several hours, a couple of days a week, to get that filtration out because their kidneys are not functioning properly. I need a high flow, so I need arterial pressure, arterial flow, but how difficult is it to continue to cannulate 3-4 times a week an artery? It's pretty hard, right? They're not right there, you can't really see them. So one of the procedures that we do in medicine for patients who require hemodialysis is we do a fistula, where I take a branch of the artery and I intentionally sew it into a superficial vein in my extremity. And then over a course of a couple of months, some changes occur in that vein because now it's seeing a higher pressure, a higher volume that normally is designed to handle all at once. And now, after a couple of months, I can use that access point to cannulate and get arterial blood flow. But I can see it, I can feel it, and it's much easier to cannulate than having to find the artery all the time. So iatrogenically, we can induce this condition, and it has a benefit to it. But what happens if this arterial venous malformation occurs in the face? Now you're having all these superficial veins that should be very minimal, where you have to look very closely to see that vein. Those become larger. They're now having a larger volume of blood. Imagine what that's going to do, especially from a cosmetic standpoint. Okay? And you can see in this little girl here what that would look like. Okay? And so it can be cosmetically, it's not medically a problem, but cosmetically, the patient can be very distressed by having this condition. So if they were to have an AVM, then we can do things like embolization, where I'm passing catheters into where that AVM is occurring, and then I can inject a coil into the area that then induces a clot formation, which then closes off that, so you're not having all that blood going directly into the vein, and then the veins get smaller, so I could do that. Or I can inject something into the skin around the area that causes a hardening of the artery or of that vein to the point where it goes away. Okay. So that's how I can treat AVMs. They typically are benign, but in certain situations we may want to do some type of procedure to treat it. So let's go back to the clinical correlation and we'll be done with our lecture for today. So the ER staff at Naval Medical Center Portsmouth did the appropriate thing after they saw this pain out of proportion to exam with the abdominal exam, right? So they ordered a contrast CT of the abdomen and the pelvis, and they found that he had a complete occlusion of the superior mesenteric artery. We brought him back, vascular surgery was consulted, we brought him back to the OR. We did a thrombectomy, an open thrombectomy, an open abdominal thrombectomy. And then the concern is, well, how long has this been going on? He presented 3 days ago to an outside ER for this abdominal pain and they didn't do anything about it. Now we see this clot. When did that clot develop? Was it 2 hours before he came into Portsmouth or was it 3 days ago? We don't know the answer to that. So we also didn't know what the complications, consequences of having this condition was going to be. So we did a procedure where we injected like a fluorescein stain into his blood vessels, and then we took a black light and we kind of put it over his abdomen, his intestines, to see what fluoresced, what glowed based on what we gave him. And then we're like, okay, there's some perfusion going on, that's okay. We didn't do any other procedures on the intestines on that first time, but we anticipated we were going to have to go back to the OR again. So we did a thing called blue towel closure. So instead of suturing the abdomen closed, we left the abdomen open and just put a blue towel in there and then sealed it with like saran wrap and a surgical saran wrap. And then we brought him to the ICU because if my abdomen is open, I can't breathe, right? So he had to be intubated. So we had to bring him to the ICU. The next day we go back and we do the same thing, and now we find a section of 40 centimeters of the small intestine is dead. So we removed those 40. Brought him back, blue towel closure to the ICU. We go back the next day. Oh, there's now another 20 centimeters that are dead. And then we just kept going on and on and on until the entire distribution of the superior mesenteric artery was gone. So what does that mean? What he had left was stomach, first part of the duodenum, descending colon. It's all he had left after we removed all the dead intestine. So he lost most of his duodenum, his jejunum, his ileum, his ascending colon, transverse colon. All of that was gone because of that. So imagine the consequences on his health. Can he eat and get nutrition if he doesn't have any small bowel? The answer is no, right? So he then becomes total parenteral nutrition, or TPN dependent, to get any kind of calories or nutrients or water or anything like that. So for the rest of his life, he's going to be dependent on an IV of sugar water with fats and lipids and proteins and all that kind of stuff to provide him some kind of nutrients. But you can also imagine, if I'm injecting sugar directly through a vein, probably an increased risk of infection, right? So a lot of people who are TPN dependent actually die of infections, not necessarily from their condition. Okay. So that was one problem with at least chronically long-term. In the beginning of the case, I told you he was a chronic alcoholic, right? Well, we're not giving him alcohol anymore, so he starts going through alcohol withdrawals. But because he was such an alcoholic, we had to give him massive doses of benzos in order to treat his alcohol withdrawal symptoms. Because the two substances that if you go through withdrawals you can die from because of that withdrawal is alcohol and benzos, right? Not cocaine, not meth, not narcotics, but benzos and alcohol are two things that could cause you to die if you go through withdrawals. Once we got him through the alcohol withdrawals, we then had to get him through his benzo withdrawals because we were using such massive doses of benzos to treat his alcohol withdrawals that he started to go through withdrawals of the benzos. So you can imagine this time frame that he was in the ICU getting all this done, as we also are managing the main problem that he came in to see us for, which was the superior mesenteric artery occlusion and the consequences related to that. Now, social kind of complications to this is, I'd say he's a chronic alcoholic. Do people with chronic alcoholism tend to have any kind of relationships? The answer is no, right? They usually push people away, right, because of their alcohol consumption and all that kind of stuff. So when we were going through all of this, there was no family at the bedside. There was no power of attorney to tell us what to do, what not to do, how far can we go, should we withdraw care. There was nobody to advocate for him. So we had to convene an ethics committee. So hospital staff who are designated had to come together to discuss his case and figure out what they would recommend doing for him. So no loved one was there to advocate on his behalf. So you can imagine, just from a superior mesenteric artery, we had so many other things that we had to manage in this patient, including social challenges that made taking care of this patient quite difficult. He wasn't out of the woods when he left the hospital, because now he requires TPN to survive. So interesting case, kind of highlights what we talked about today. Hopefully you found that educational. But these are kinds of things that as you get into phase 2, you're going to start to accumulate these interesting cases that you're then going to use to educate maybe your patients, maybe some